let's review fluid and electrolytes, just the basic principles. So you know there are two fluid compartments in the body. Water can be inside the cell or outside the cell. When we say outside the cell, there are only two other places it could be. It could be in the bloodstream, in which case we have three blood vessels, types of blood vessels. We have the arteries, veins, and the lymphatics. And if it's not in the blood vessels, then it has to be in between blood vessels and in between cells. Okay, so only two, again, compartments in the body. Fluid can either be inside the cell and then outside. When we say outside, it's either in between blood vessels, capillaries, veins, arteries, or somewhere in between. Okay. Now, there are passive and active processes in the body, and these are automatic. It won't ask your permission. It will automatically shift fluids from one compartment to another. So water composition changes all the time because every second there are chemical processes that occur in the body, and these are influenced by our fluid intake or the lack thereof. For instance, there are chemical reactions that produce extra fluids, and the elimination of those fluids are also affected by certain conditions. Okay, so we will discuss those factors today. So I already mentioned this. So these are the average distribution of fluid throughout those three, or technically two, compartments in the body. Yes, sir. This is your textbook. Yeah, this is the 15th edition. So if you're using the ebook, this is the ebook I'm using. If you're using, well, you should have access to this anyway, because you're on Course Point. So everybody has access to the ebook. Let me explain the concept of third spacing. Now, technically, when we say edema and third space, it's actually referring to the same thing. The fluid is not inside the cell. It's not inside the blood vessel. It is somewhere in between. They should not be there. Okay, this is extra fluid that should not be in between cells and blood vessels. Okay, they got there by two different mechanisms. That's the main difference between edema and third spacing. When we say edema, we got the fluid there through hydrostatic pressure. What is hydrostatic pressure? Force exerted by a liquid. Okay, so that usually results from congestion. Now that congestion is usually inside the bloodstream, meaning when we say edema, that fluid came from the blood vessels. So congestion can be caused by a number of factors. It could be caused by a circulation problem. So let's say someone's was compressed, a part of your body was compressed, causing congestion in one or more types of blood vessels, or it could be congestion inside the heart. So edema can occur in any part of the body. There could be edema inside the brain, in your brain cells. It could be edema in your lungs. It could be edema in the peripheral parts of your body, or there could be edema in your abdominal cavity, right? But when we say edema, how did that water get there again? Hydrostatic pressure, usually caused by congestion. Okay, so there's congestion. Again, there are many processes wherein we can cause congestion. A number of things can go wrong in your body, causing congestion in one or more blood vessels. When we say third space, this is not hydrostatic pressure. This is caused by an imbalance in the concentration of one or more fluid compartments. Again, I repeat, when we say third space, it's caused by an imbalance in the concentration of one or more fluid compartments. However, when we say pulmonary edema versus ARDS, wherein it will still result in pulmonary edema, when we take an X-ray, whether it's third spacing or edema, it looks exactly the same. What's the main difference again between edema and third spacing? It's just the mechanism, okay? How did that form? What caused the edema again? Hydrostatic pressure. What caused the third spacing? Imbalance in the concentration, okay? Now, therefore, are all edema and third spacing treated the same way? No, because there are different mechanisms by which they form. Are you following so far? Yes. Okay, so therefore you can't treat every edema or third spacing the same way. You have to look at, the doctors have to see what is the cause of this? How did this pulmonary edema occur? Right? So especially pulmonary edema, because pulmonary edema can be caused by the, like I said, imbalance between the concentration of the fluid compartments, or it could be caused by congestion. Congestion can be from heart failure or from obstructed circulation. Okay. Let's finish up with third spacing. Now, the third spacing is influenced by osmosis. What is osmosis again, if you remember from A&P? So I'm sure Dr. Farrington explained this very well. From where to where? Ms. Rivera, right? You, Ms. Rivera? Okay. So, Ms. Rivera, movement of water from where to where? Very good. From low concentration to high concentration. Now, this is the law of nature. Okay, this is a passive water movement. Water will automatically move, okay, whether they have your consent or not. It will move whenever there are changes in concentration. It will always move from an area of lower concentration to an area of higher concentration. So to apply this, let's go to one example is on IV fluids. Okay, so you know what? Let's do the IV fluid example later when we get to the IV therapy. Let's use an example of, let's get to the diabetes also when we get to that diabetes chapter. I have to give you an example. Let's use the hyperglycemia. Okay, so you don't have to be diabetic to have hyperglycemia. It could be, let's say, you went to a buffet. So you picked out, right? So buffet, you paid 20, 30 bucks. Buffet. So of course, are you just gonna go take one trip to the table? No, you're wasting your money. You gotta get your money's worth. You gotta go 3, 4, 5, 6 times. Okay, spend all day there, whatever the time limit is. Okay, so dinner buffet starts at 5. I'll be there until 4:59 for lunch. Okay, so let's say you did that, and then my sugar went higher and higher, right? So what did you notice hours after pigging out? What did you do to the, as far as number one, going to the bathroom? How many times did you go? Multiple times, right? Let's not talk about diarrhea, just number one. Okay, so that means it increased your urine output. Why did that happen? Because you have a lot of sugar. Okay, so that's number one example. If the concentration of your bloodstream, because now at that point your pancreas can't produce enough insulin, because this is not, it's not like you eat buffet every day. This is one time, and the pancreas wasn't given a heads up. It didn't send a message, hey pancreas, I'm going to lunch buffet today. Okay, don't forget. Okay, you better increase your insulin production. You didn't give him a heads up. So all of a sudden, your pancreas can't keep up. So you had hyperglycemia for a couple hours. So during that time, what happened to the number of sugar molecules in your bloodstream? It increased. So therefore, what happened to the concentration of your bloodstream? Increased. Your blood became very thick. Now again, according to osmosis, you change the concentration of your bloodstream. So water has to move, correct? But where will water move to? From the cells. It will grab water from the interstitial space, in between, and water from your cells, inside the cells, will come out and go into the bloodstream to maintain homeostasis. The concentration among all three fluid compartments must stay the same, but you changed it because of your buffet trips. Okay, so increase the tonicity, or you increase the osmolarity of your bloodstream. So therefore, what happened to your urine output now? It increased because the blood volume increased, right? You added water there, all water from your every cell in your body, including the brain, GI tract, everywhere, went into the bloodstream, enough to equalize the concentration of all three compartments. Now, of course, the kidneys will do what? Granting your kidneys are functioning well, what will they do? All this excess fluid in the bloodstream, and this is circulating into your nephrons, what will they do? Because that's the kidney's job. Okay, too much water. Okay, there's too much blood volume. Let's get rid of it. So now you are peeing a lot and frequently. Understand? So that's an example. So let's look at later when we get to IV fluid. So this will explain why doctors provide or order certain types of IV fluids, IV solutions for each particular reason. Okay, so it all depends on what purpose is the IV fluid given for, right? Are you trying to increase blood volume? Are you trying to maintain fluids, or are you trying to get rid of fluids? Kind of ironic, right? You're trying to give fluids to get rid of fluids. Yeah, but that's an example. So that's osmosis. Okay. Now the difference between the three, osmosis, of course, is the process, right? That's the mechanism. Osmolality and osmolarity, they refer to the concentration of a certain solution. That solution could be your blood, it could be cerebrospinal fluid, it could be your urine. Okay, any fluid, anything wet in your body has a certain osmolarity, has a certain concentration. That concentration, again, can be affected by any number of factors. All right? Any questions so far? Yeah, I won't discuss the entire chapter, okay? So let's go now to how are they regulated. So we already explained the passive mechanisms, which is osmosis. Okay, that's the most common process that occurs in the body. Please play the video on your own time. I don't have time to play that. So I described the hydrostatic pressure already. So this is the process responsible for forming what? Edema. Okay. What about the third spacing? What's the cause of that again? Okay, the change in the concentration. These are your electrolytes. Some test questions will give you the normal values, especially next generation type questions. Some of them, no. Okay, some of them will just give you the lab results with no reference value. So please recall if you don't remember the value. So we'll use your textbook, okay? So sodium will be 135 to 145, potassium 3.5 to 5. Calcium 8.8 to 10.5, magnesium 1.8 to 2.6. I'm not saying the others are not important, but for our purpose, we'll only be testing, at least for fourth semester, exam 1, sodium, potassium, calcium, and magnesium. Okay. We'll get to phosphorus later when we get to the endocrine problems, which is exam 2, I think. So this is again the description. If you're a visual person, so this is the process of osmosis. The goal of the body again is to equalize the concentration. Now, because large molecules cannot pass through membranes, so only water can. Water molecules are small enough to pass through semi-permeable membrane, so only water can move, okay, not the large molecules. Okay. So for in the case of glucose earlier, so how do you move glucose into the cell? You need insulin. Okay, so is it possible to put glucose into the cell, meaning you can't take it out of the bloodstream unless you have insulin? Oncotic pressure is pretty much the same as osmotic pressure. Okay, so when we say oncotic pressure, that's the pressure exerted by a fluid on the cell membrane. So here are the solutions now. So tonicity is referring to the osmotic pressure or concentration of a solution. Now we have solutions mentioned here. So crystalloids are the following. So you've got saline, half normal saline, LR. These are crystalloids. We use them for rapid hydration, different purposes, obviously. Isotonic solutions there are three. So we have NS, normal saline, or 0.9% sodium chloride, and LR, lactated ringers. It's also isotonic. And the other isotonic is 5% dextrose in water. That's also isotonic. So only three isotonic solutions. Half normal saline is hypotonic. Why is it hypotonic? Because it's half the concentration of 0.9%. Okay, so how did they decide? 0.9% sodium chloride and LR have the same concentration as plasma. What is plasma again? The liquid portion of our blood. So when you get a blood sample, what makes it red? Okay, because there's red blood cells there. But if you spin it, put it in a centrifuge by centrifugal force, you force the cells and separate them, you're left with the yellow liquid, which is the plasma. Plasma contains water. It's about 70% water, about 20-something% protein, and the rest are clotting factors, glucose molecules. That's what plasma is. And these are the colloid solutions. These are very thick solutions. Okay, blood products like albumin solutions, dextran. So we use these to, because they're very concentrated, what will they do to the blood volume? Thinking about osmosis. They will increase blood volume. However, they will do so without the volume. Because let's say there's a number of ways to increase blood volume. You can either give the patient lots of IV fluids. That's the, easy way to do it. However, if a patient has any heart or kidney problems, can they handle volume? They cannot handle large volume. So if the doctor wants to increase or expand volume without adding additional volume, meaning what the doctor wants is just there's enough volume in the body. We just need to shift them around. Okay, we don't want to add anymore. I just want to increase intravascular volume without adding lots of fluids. So they'll do that with albumin or dextran. Does that make sense? Yeah. Do you understand the concept? Meaning this will shift water. Okay, so let's say dextran. So this will improve blood volume, improve blood pressure without adding lots of IV fluids. So how did it do that? It shifted fluids. So it grabbed fluids here and there from the cells, from the interstitial, and put it into the bloodstream. Okay, that's how it increased blood volume without adding additional volume, meaning it's already in the patient's body. We just shifted them around. Does that make sense? Because you can do that, especially with compromised patients. Like I said, heart conditions, kidney problems. Those patients cannot handle additional fluids. Okay, so you just need to shift what existing fluids are in the body around. So as I said, isotonic solution. So let's discuss who would benefit from isotonic. What are the three isotonic solutions? And D5W. Okay. So because they are the same concentration as plasma, and as described here, isotonic solutions do not provoke water movement. It will not cause any water movement at all. So therefore, who will benefit from these types of solutions? I'll answer that with a qualified yes, correct, but that's not really 100% accurate. But yes, we will give isotonic solutions to dehydrated patients. However, well, what is the purpose of giving isotonic solution? What are you trying to do? Because when you give this solution, let's say you have an IV catheter, then you put this up on the pump, you begin infusing it. Where will this solution go? It stays in the bloodstream. So therefore, okay, patients with low blood pressure. What else? Okay, low blood, yeah. So bleeding patients, yeah, shock patients. Okay, so anytime you want to increase blood volume and increase blood pressure, this is your best friend. All right, so either LR, we expect that order for trauma patients, post-op, or let's say a trauma victim. They won't order saline, they'll order LR, okay, LR bolus. Okay? So because it has some electrolytes, so better than NS. Okay. Question, Lewis? Okay. Let's go to hypotonic now. Hypotonic, obviously less than 0.9% concentration. So we have a few only. We have 3 for iso. We have only 2 for hypo. It's either 0.45 or 0.225, even less than, a quarter of 0.9% NaCl. So who would benefit from this? So since this has less solutes, because as you know, the tonicity of a solution depends on how many molecules are in that solution, correct? Meaning, let's say, between coffee and tap water, which one has a higher tonicity? Coffee, because it has coffee and sugar and milk, whatever you put in that coffee, okay? So that determines the tonicity of a solution. It's really what is in there. So since 0.9 is basically salt water, right? There's sodium and chloride in there. LR, yeah, there's still a sodium and chloride there, but there's also potassium, magnesium, and other elements there. Hypo has very little. So this has lesser concentration compared to plasma. So when you give this to somebody, where will this go? Look at the statement. Yeah, so this can be used to move water from where? Into the cell. Okay, so from the bloodstream, obviously, because you give this into IV, right? You give this in the bloodstream, where will this go? Into the cells. So therefore, what could possibly go wrong if you give someone half normal saline or hypotonic solution for a long period of time? Edema. The cells will swell up, especially the brain. Okay, so our number one concern whenever, so always look at it. When your patient is on half normal saline, check how long has this been going on? When was this ordered? Okay, how many days have they been on it? Then look at the urine output. Are they making enough urine output? There should be a balance, right, between intake and output. And then always check neurological status because we're concerned with cerebral edema. When this patient shows any signs of increased intracranial pressure, number one is change in the level of consciousness. Patient is now lethargic, or there's confusion, right? Or they're having seizures now. That's evidence of cerebral edema. Okay, so very dangerous if you put someone on this for a long time. Okay, so always monitor. Same thing for isotonic. So what's your concern with an isotonic solution? So you're concerned of overload, fluid overload. Okay, remember, can this cause this congestion? Yeah. Yes, because you're basically overloading the heart, right? It's now increasing the workload of the heart with this type of solution. So whichever solution you're giving, always monitor the effects on the patient. Don't just because it's ordered, right? And then you keep infusing it. Always look at is there still a reason? Okay, does the reason still exist? Okay, does the patient really need this? Right? Because doctors can't forget about it. Okay, they just order and then 3-4 days later, the hell's going on here? So you start to question. Okay, so why patients eating? Okay, because you and me, are we getting IV fluids? No, for eating, drinking, fine, we don't need fluids, right? So same thing. These are same humans. Hypertonic. So this is anything that has dextrose in it. 5% dextrose, 10% dextrose. What's the only exception? 5% dextrose in water. Okay. So that's the only isotonic solution. Anything else, D5 normal, D5 and a half, D5 LR, anything with dextrose in it is a hypertonic solution, meaning it has higher concentrations compared to the bloodstream. So where will this thing go? What will this thing do? So here's the solution. The movement of water will be from the intracellular into the extracellular, into the bloodstream. So it will draw water out. So what's the benefit here? What patients will benefit from this thing? Patients with cerebral edema, any edema. Okay. So you may say, why am I giving fluids? This patient already has edema. Remember we said earlier that there is two mechanisms, right? It's either third spacing or hydrostatic pressure. Okay. So in this case, here, particularly cerebral edema. So you have two options here. The doctor can either use a hypertonic solution, let's say 3% saline, for instance, or give them a osmotic diuretic, which works the same way. So it's just up to the doctor. Okay, so here, like, for example, this is a osmotic diuretic, mannitol. We give this for head injury patients, stroke patients, head trauma patients, okay, or head surgery patients. Okay, so we give the mannitol or hypertonic saline. The decision again, whether or not to use the mannitol or the hypertonic solution is based on, can the patient handle fluids? If the patient can't handle fluids, will you give hypertonic solutions or mannitol? We'll give mannitol. Okay. Okay, osmotic diuresis, I already gave the application on this on, remember the hyperglycemia example we did earlier? So that's what we call osmotic diuresis. So when we get to DKA, maybe next week, osmotic diuresis can cause severe dehydration. Okay, so the hyperglycemia there that the patient is in causes them to die of severe dehydration, can go into shock. Osmotic diuresis is, again, how did this occur? What happened to the bloodstream? So hyperglycemic, okay, very hypertonic. So it dehydrated all the cells because they pulled all the water. And then now the patient's kidneys, of course, have to react by getting rid of all this excess water. Then the patient is now dehydrated, could go into shock. Diffusion, the number one example here is the diffusion of gases. Again, this is a passive movement. So this is not water though. This is a substance. This is now the molecules, movement of molecules or substances from an area of higher to lower concentration. So number one example is, again, diffusion of gases. So that's why when you inhale, you have 21% oxygen, right? So it will diffuse into the capillaries. And then since CO2 is higher from the capillaries, it will also diffuse out. Okay, so exchange, gas exchange. So inhale more oxygen, you exhale more CO2. Okay, simple process. Filtration is from the kidneys. This is also passive. Filtration, just like how coffee is. So you put coffee granules. So how did the urine, or not urine, coffee, okay? How did your coffee form? Because it filtered the granules, right? So same thing, your blood is filtered by the nephrons. So it will filter large molecules like sugar, red blood cells, electrolytes. It will be filtered, and then out comes urine. So this is the only active transport, sodium potassium pump. Let's describe it because this will be relevant when we get to heart failure treatment. So sodium potassium pump is active transport. So this is made possible only by ATP. So you need power to transport sodium and potassium in and out of the cell. So without ATP, such as what happens in a heart attack, for instance, so let's say you're having a heart attack, is there blood flow to the coronary arteries? No, it's blocked by a clot, right? So that clot obstructed blood flow. So therefore, is there oxygen to those distal parts of the heart? No. So are they making ATP because there's no oxygen? No, you need oxygen to make ATP. So therefore, no ATP, no power. Can sodium potassium pump be possible for those cells? So therefore, does the heart function at that point? No. You need ATP, right? So no ATP, no sodium potassium pump, no power generated. It's simple as that. And as far as the ECG changes, we'll discuss that when we get to module 8. So for the, arrhythmias. Okay. All right, so at any given day, our fluid balance should equal 0. Although it's not always like that because we do have insensible fluid loss. As you can see here, we can measure what we drink. However, do you eat like dry rice or hay? You eat hay? No, but cows eat hay, right? So that means, does hay still contain water? Yes. Okay. If you don't believe me, start eating hay and you'll be okay. Okay. So there'll still be urine output. So it's about from water oxidation, from the food you eat, the fruits you eat. So those are water. So that's about 2,500, give or take, each day. As far as output, majority is urine. So 1,500 at any given day, given you have normal or average intake. So you make about 1,500 total per day. But we have insensible losses. So we can't, there your breath is wet, right? So you're losing water there. The more you talk, then the more water you lose. You exercise, so you sweat, depending on your level of exercise. So we lose more water in the summer, correct? So that's insensible fluid loss. Feces, do you ever pass rock hard stools? Or some do, right? But even though, if you don't believe me, try squishing that, put that in your, in between your textbook, and you will still get water out of that rock hard stool. Again, you don't believe me, try it. So we can't really get the 0, okay, balance because of these insensible losses. So the average sensible loss is about 1,000, but it could vary depending on the season. Okay, you sweat less, of course, and you talk less, of course, you lose less. So it's anywhere between 600, a minimum 600 to about 1,000. All right. So we consider that also when we get to chronic kidney disease. So dialysis, those patients become oliguric. What is oliguria? How much exactly? Less than 400. So if your patient's peeing less than 400 ml per day, that's called oliguria. What is anuria?
Absent.
0 to what? Because it's not really 0. 0 to, okay, less than 100. So if you have less than patients peeing less than 100 ml per day, that's anuria. Okay. Now, some patients on dialysis, it's not really that they don't pee. Okay, they pee very little though. They just dribble. So do they even talk about that? Is it worth talking about? No, you call that peeing? I just dribble like this, a few drops. So they don't even mention it. That's nothing. Okay, it's not worth counting as a urine output. So there's really no such thing as 0. They pee, but very, very negligible. Okay, 0, 30 ml here, 20 ml there. It's like a tiny little cup, right? Sometimes they don't even know. Is that pee? Now the kidneys. So we have 2. Now this is the majority of how we get rid of water. So its major function is to balance fluid volume. Okay, these two kidneys decide how much water to retain and how much to get rid of. Skin, of course, we lose water there too. Lungs, as we already described. Okay. The best example here is the Titanic scene, you know, in the car, in the cargo, with Jack and Rose in the car. Okay, so they fogged up all the windows, right? So that's where, you know, lungs, you lose a lot. So look at that, 300 ml per day. And GI tract, of course, depending on the consistency of your feces. All right. So it's really critical to do a careful assessment of your patient. Where is the patient losing water from? So some patients have profuse diuresis, certain conditions, and they sweat a lot, they soak the bed. So consider that. Okay, that's a lot of fluid loss. Or let's say they're breathing 30 breaths per minute. Are they losing a lot of fluid? Yes. Okay, so patients, anytime the the respiratory rate goes over 20 breaths per minute, consider fluid loss there. Okay, so you wonder, oh, why is this patient on IV fluids? Because of that. Okay, because they're breathing so fast, they're losing so much water. So doctors get concerned, they give IV fluids. Okay? Plus, patients like that in respiratory failure, for instance, do they have a choice between drinking water and breathing?
No.
Can they choose? I'm tired of breathing. Okay, not really a choice, right? Okay, let's go to labs now. So we're trying to see signs and symptoms, and the next topic will be there are only two problems with fluid imbalance. So it's either high dehydration or fluid overload. So we'll look at the indicators. Okay, so how do we know our patient's fluid status? What do we look at physical examination wise and also laboratory wise? Okay, we'll get to that. Very good though. Most accurate is the weight. Okay, with one exception. Okay, we'll do that in next semester, which is burns. Okay, so burns is the only exception, but all other conditions, weight is the number one indicator, right? In dialysis, we use that a lot. So 1 kilogram of body weight gained or lost is equal to 1 liter of fluid. Fluid, okay? Water, sorry, one liter of water, not soda, not ginger ale, okay? Not juice, but water. So 1 kilogram gained or lost is equivalent to 1 liter. 1 pound gained or lost is equal to 500 milliliters. Okay, it's somewhere here. Yeah, we just didn't get to that. Well, Jennifer started the weight, so I had to discuss it. Okay, so let's look at the other indicators. So let's start with serum and urine osmolality. What is osmolality again? The concentration. Okay, so serum refers to your blood, correct? So we draw a blood sample. Osmolality is high. What is the patient's condition? Dehydration. Okay, so deficit means because is there enough fluid in that blood sample? No. So therefore, if you don't have enough fluid, so now the waste products, the red blood cells, whatever is in the blood is now all of a sudden higher, right? So that increases the concentration or the osmolality. Same thing with your urine. How much urine will the kidneys make if you don't have enough fluid in your bloodstream? No, less blood pressure, less blood volume circulating to the nephrons. What will the kidneys do? Make more? No, just like you and me. We have no money. Let's say payday is not until the 19th, right? At least for me. The 19th is my next payday. I have 10 bucks to my name right now. What will I have for dinner? Will I go have steak tonight? No, I'll be on ramen from now until next Friday, right? Yeah, yeah. Buy a dozen eggs and 2 packs of ramen. I'll be fine until the 19th. Okay, so same thing. Kidneys will conserve water. Okay, there's not enough. It will, of course, conserve water, causing less urine output. And then what will that urine output look like? Because it has less water, darker, so therefore higher urine osmolality. Same thing with the specific gravity, which will be somewhere here. Okay, so here, specific gravity. So normal is between 1.005 to 1.030. So if it's a dehydrated patient, concentrated urine, what will the specific gravity be? Higher than 1.031 and higher. What if it's the other way around? What if it's fluid overload? What will the specific gravity be? 1.004 or less. Okay, so here are the two major problems. So let's start with osmolality. So we discussed a few moments ago. So when you have dehydration, of course, we'll discuss this problem today. We'll discuss diabetes insipidus. And then the opposite counterpart here with fluid overload is SIADH. Okay, so those would be our two examples today. We'll see if we can get to heart failure and kidney failure today, because those are also fluid and electrolyte problems. Okay. By the way, you understand concepts, right? What does it mean when you say concept? A concept is an idea, right? So fluid and electrolyte concepts. So that's what we're doing today. And then after we finish with this intro, we will now look at specific examples of fluid and electrolyte problems. Okay, so number one will be these two, okay, diabetes insipidus and SIADH, which are emergencies. Okay, these two conditions are life-threatening. Then we'll look at chronic conditions as well, just like chronic chronic kidney disease. AKI is included here because the first phase of AKI is like CKD. Okay? The patient is in fluid overload. We won't do the whole thing, but these are examples of conditions that can lead to dehydration. Stroke. So you might wonder, how does stroke or head injury lead to dehydration? Well, it can cause diabetes insipidus. Okay, so diabetes insipidus, like I said, this is life-threatening because it's a complication. It doesn't exist on its own. It's a complication of another condition. So those conditions are either stroke or head injury, or it can also occur in patients with brain tumors, okay, stuff like that. Okay, so you can develop diabetes insipidus. Urine, we already discussed extensively. All right, let's go now to enough with the urine. Let's go to the blood now. So what is BUN and creatinine? Why are they very reliable indicators of someone's fluid status? Okay, so BUN is a waste product. It is a nitrogenous waste product. So where does it come from? Nitrogen. So anything you eat that has nitrogen, which is basically everything, right? Especially meats, okay, high protein stuff, peanuts, meats, steak, high protein, eggs, high protein foods means what will it do to your BUN levels? Let's say you're an athlete like me, I work out a lot. So what will my BUN levels be? I will have higher than normal BUN levels because I work out a lot. I should really cut down on that. Okay? Creatinine. So what is creatinine? Another waste product, this time from muscle metabolism. So every time you contract your muscles, doesn't have to be like my intensity, like I do a lot of push-ups. It doesn't have to be like that. It could be like blinking, okay? Blinking your eyes like this. So anytime your muscles are contracting, you are making creatinine. Okay. So whose job is it to eliminate these two, BUN and creatinine? Kidneys. So therefore, are they directly related to the amount of urine you produce? Correct. So the more urine you make, the more BUN creatinine you get to get rid of. The less urine you make, the less you also get rid of these. Okay, so that's why it tells you here in between this paragraph here, it tells you what will affect BUN creatinine levels, right? Yeah, so GI bleed, that means your volume depleted also, right? That's equivalent to, yeah, to dehydration. Okay. And of course, BUN creatinine indicates if the levels are high, that means are your kidneys working really? So does this also indicate kidney injury?
Yes.
Okay, very good. Hematocrit and hemoglobin. Hematocrit is what? Percentage of red blood cells in a given blood sample. Okay, normal is between, since there's a male and female here and your patients on the exam won't have a gender, I'll just say client. So go with the lowest and the highest between the two. Are we clear? So for you, since I won't give you a gender, I'll just say the client. So your normal will be 35 to 52. So if a patient's creatinine is 55, what's the patient's fluid status?
They have over
Deficit. If the hematocrit is 31, they're in fluid overload. Are we clear? Okay. So this will be relevant. Let's say your patient's on IV fluids. What will you expect the hematocrit to be? If let's say I'm normal, I have no problems, and then you start giving me fluids, let's say 100 ml per hour, what will happen to my hematocrit? It will drop. Okay, so we call that hemo concentration. Okay, it's not like I lost blood. You just added fluid to my bloodstream. So therefore, when I draw a blood sample, of course, that blood sample will show a little bit diluted. Okay, so the hematocrit will decrease. And then vice versa. If you're losing fluids or dehydrated, what will happen to the hematocrit? 58, 59, 60. Okay. What about hemoglobin? So they didn't mention hemoglobin here, but it's also included. So if hematocrit rises or falls, hemoglobin will also rise and fall. So hemoglobin are proteins, right? So therefore it's measured in weight. So they measure hemoglobin in how many grams, okay? Whereas hematocrit is measured in percentage, because this is the percentage of red blood cells in a given blood sample. All right, let's discuss the two mechanisms here. We have the renin-angiotensin-aldosterone system, and then the sympathetic. But I think only the renin-angiotensin is mentioned here. Okay, so what's the role of the kidneys?
maintain homeostasis.
All right, so the good thing we have two of them, because we need two. There's when we get to AKI, I'll probably, but we're here till 4, right? Maybe we'll get to, yeah, we will get to kidneys, okay, on the 3rd hour. Heart and blood vessels. So the blood vessels here are referring to the arteries specifically, because they're the ones with muscles. Veins really don't have muscles, so they can't contract and relax. So this is referring to the arteries. So they can constrict and dilate in response to our body's needs. Okay? Also affected by the renin-angiotensin-aldosterone system. Heart, of course, the heart can increase or decrease the heart rate, controlled by the autonomic nervous system. Lung this is where the angiotensin comes from. Renin comes from, and we'll explain again the whole process shortly. And the other is the pituitary, so the hypothalamus and the pituitary gland are working hand in hand here. So one reaction is to release antidiuretic hormone. So this is the problem found in diabetes insipidus and SIADH, which we'll discuss on the second hour. So this response is the release of ADH is, well, to make the long story short, the hypothalamus makes it. The decision to release or not release it is determined by the pituitary gland, okay, the master gland. So the pituitary gland constantly monitors, okay, the bloodstream, the concentration of the bloodstream. So when it senses that the serum concentration is high, which occurs in dehydration, correct? Meaning the serum osmolarity is high, right? Which occurs in dehydration, correct? If it's high, then what will it do? How? Releasing antidiuretic hormone. Okay, so automatic senses, oh, what's happening? High concentration of the blood, serum osmolarity is high. I will release antidiuretic hormone immediately. And what will the ADH do? This will command the kidneys to reabsorb water. Kidneys will ask, how much? Well, just respond. So the higher the ADH level, then the more water will be reabsorbed. Okay, it's depending on how much is the serum osmolarity. The higher the serum osmolarity, then the more ADH will be released. Does that make sense? Okay. So here's the renin-angiotensin-aldosterone system. We'll discuss this and then you go on a break.
I mean, it's not like the birthday. I have it birthday.